All right, if everybody could take their seats, we will get started with this afternoon's section. For the next hour, we'll be talking about hot topics. And we have 4 different presentations from Dr. Paulo Silva, Dr. Amanda Bickett, Dr. Fernanda Albalam, and Dr. Jeff Sundstrom, and a wide array of topics that I find actually quite interesting. Without further ado, I'd like to introduce Dr. Paulo Silva. He'll be talking about the awareness crisis in diabetic retinal disease. He's a staff ophthalmologist and co-chief of telemedicine at the Beetham Institute at the Joslin Diabetes Center, and also an associate professor of ophthalmology at Harvard Medical School. So without further ado, let's get started.
So good afternoon, everyone. So it's a pleasure to be here at the MTM Vision Initiative. I'm here to highlight some of the data that we have that really emphasizes that we are in an awareness crisis for diabetic retinal disease. So let me start by sharing insight from the enhanced data set. So being unaware of one's retinopathy is a pathway towards blindness. So lack of timely evaluation and follow-up, there's this tremendous amount of data that really highlights why patients need to be aware that they have retinopathy. Only 63% of US adults with diabetes have annual eye exams. And based on this data, it's been constant over the past 14 years. And eye care utilization in patients with advanced disease has been reportedly been very low. It's estimated that 1- and 2-year rates are at 33% and 45% respectively. Retinopathy unawareness also contributes to non-adherence with timely follow-up and increases the risk of visual loss. This is from enhanced data again. Patients 40 years and older with DME, only 45% report being told that diabetes had affected their eyes. So we conducted a study at the Joslin Diabetes Center to assess self-reported patient awareness of DR and concordance with scheduled follow-up with national guidelines among a large cohort of diabetic patients evaluated over an extended period of time at the Joslin Vision Network Telemedicine Eye Care Program. The secondary study objectives were to assess the associations with the specialization of the eye care providers and to assess changing trends in awareness or follow-up concordance over the 10-year study period. These results have been published earlier this year in Diabetes Care and represents data from over 25,000 patients over a 10-year study period. This was a prospective cross-sectional study looking at all new diabetes patients seen at the Joslin Diabetes Center between January 1, 2010 to March 31, 2020 who had not been previously received eye care at Joslin's Beetham Eye Institute. Each patient was asked these following questions. When was your last eye exam? Who performed your eye exam? Were your eyes dilated for a retinal examination? When is your next scheduled eye exam? And are you aware of any diabetic eye complications? Certified imagers then acquired non-mydriatic images following a validated protocol. Images were evaluated for diabetic retinopathy severity and the presence of DME using a standardized reading center protocol previously validated against ETDRS fundus photographs and clinical examinations by a retina specialist. For the purposes of this study, follow-up was not considered in agreement with national guidelines if no exam was scheduled, or the time to scheduled eye exam was longer than that suggested by national standards for the severity of DR present on the patient's retinal images. So we enrolled 25,360 patients. 55.6 had no retinopathy, 26.8 had mild retinopathy, and 16.7 had vision-threatening retinopathy, defined as moderate NPDR or any level of DME. Across the 3 cohorts, mean age was 53 years old. With increasing retinopathy severity, we see longer diabetes durations and higher hemoglobin A1C. In this cohort, about 60% had type 2 diabetes. So this figure shows the reported time since last eye examination. You can see in all three cohorts, 40% had an eye exam longer than 1 year. But what's particularly striking, in eyes with vision-threatening retinopathy, nearly 6% had an eye exam between 6 months to over a year. So this figure shows the unawareness of retinopathy by DR severity. In patients with no DR, as expected, 97% were unaware they had retinopathy. This is very consistent. In patients with mild NPDR, 89% were unaware of their retinopathy. But what's particularly striking, in patients with vision-threatening retinopathy, 55% were unaware that retinopathy was present in their eyes. Similarly, this figure shows concordance with national guidelines for follow-up by DR severity. You can see in eyes with no or mild NPDR, 28 and 21% had follow-ups longer than recommended or had no scheduled follow-up. In eyes with vision-threatening retinopathy, 66% were discordant with national guidelines. So we looked at retinopathy awareness in patients with vision-threatening retinopathy by eye care provider type. You can see in this cohort, with increasing provider specialization, the rate of unawareness decreases. But even in those patients under the care of a retina specialist, 41% remained unaware of retinopathy present in their eyes. Similarly, concordance of follow-up with national guidance in patients self-aware with vision-threatening retinopathy by eye care provider type. So these are patients with the highest severity of retinopathy, and they were aware of their retinopathy present in their eyes. With increasing provider specialization, we can see decreasing rates of not having a timely eye exam. But even in these very cohort that's already under specialist eye care, 25% remain that they don't have timely eye exams. So these exploratory analyses were on trends of retinopathy awareness over the 10-year study period. And you can see here at the last 3 years of the study, the unawareness increases statistically significantly. However, it's important to emphasize that across the study period, in eyes with mild NPDR, unawareness was over 85%. In eyes with vision-threatening retinopathy, this was nearly 50%. The increase in awareness translated to increased concordance in eyes with early retinopathy. However, this was not seen in eyes with vision-threatening retinopathy. So in summary, 89% of patients with mild DR and 55% with vision-threatening retinopathy were unaware of the presence of any DR. 66% of patients with vision-threatening retinopathy reported a follow-up eye exam interval longer than recommended. And even after follow-up with a retina specialist, 41% of patients with vision-threatening retinopathy remained unaware of any DR, and 25% did not report timely follow-up. Greater unawareness and more timely follow-up were associated with increasing specialization of eye care providers. Although significantly related to provider specialization, the large discrepancy persisted across all provider types. And over the 10.25 years of the study, patient awareness of eye disease appears to be improving, but concordance of follow-up with national guidelines did not change substantially, especially in eyes with vision-threatening retinopathy. Prior reports have shown that diabetic eye exams are often overstated compared with medical documentation. 48% overstated dilated eye exams, and 5.9% really overstated that they had an eye exam. If through here, the deficit in concordance with national guidelines may actually be an underestimate in this current study, so potentially the problem is even larger. So some limitations, this study cannot determine the accuracy of the patient reports, nor the causes of the underlying patient unawareness of retinopathy or concordance of follow-up with the guidelines. Potential explanations may include DR progression in the interval prior to imaging. The patient did not recall or did not understand the information presented by eye care professionals, and DR severity may have been underestimated or follow-up suggested was less stringent than recommended. So I'd like to end and really emphasize the findings of this study. Substantial discrepancies exist between patient DR presence, patient awareness, and concordance of follow-up across all DR severity levels. These discrepancies are present across all eye care provider types, with the magnitude influenced by the provider type. Modifications of medical care and education models may need to be necessary to enhance retention of ophthalmic knowledge in patients with diabetes and assure accurate communications between all healthcare providers. Thank you.
All right, as there is no panel associated with this, please stay up there, Dr. Silva. There is some time, a few minutes for questions for each of the presenters after their presentation. So if there are any questions for Dr. Silva.
Yeah, I think these are really interesting results. I think they highlight a lot of things that we already know or suspect, at least. I think it'd be interesting to look at kind of the breakdown by race, ethnicity to see if there are any differences there. Because when we think about these problems, we want to understand kind of what we can do to help.
I think one of the key findings here is really the importance of having an eye exam. When they've had a sooner eye exam or an eye exam scheduled, the rates of unawareness decrease. So we need to emphasize that. Also, we looked at, I didn't present it here, but we looked at social determinants also, whether ethnicity matters. So non-white ethnicities are typically unaware of their retinopathy. Also, patients from different income thresholds also are unaware. But surprising with the income thresholds, eyes coming from patients that are from the lowest income threshold and the highest income thresholds actually have the rates of highest unawareness. So I think the key here is that it affects all demographic groups, all communities, and the importance of having an eye exam, as well as having that eye exam, greater communication, greater quality, being able to communicate these findings better to patients.
So when I look at this data, which I think is very interesting, it brings to mind that I think the overwhelming factor here that's not measured is fear. I don't think people want to know. I think they're afraid to get screened because they are afraid that they might have something that could lead to a serious complication. I mean, the greatest thing that patients with diabetes fear is blindness. To me, it's like colorectal screening. It's hard to get people to go get those, right? Because they're afraid of the procedure. They're afraid of what the results might show. And I just think there's something going on in the background that we need to be aware of, that we need to present this as a, like a healthcare positive behavior, but it's not something to be afraid of. And that's really a high hurdle, I think, to achieve.
Yeah, so I think communications to the patients in a language they better understand, also in a way that won't make them apprehensive or anxious in any way, is very important.
Yeah. Thank you, Paolo, for a nice presentation. In Denmark, we have made a similar study, and we found that the attendance rate was not related to income, but to educational level. And our conclusion was that perhaps the doctors are unable to speak the language that is understood by all persons. Perhaps the doctors do not speak the language that persons with lower education can understand. What is your comment to that?
I think in the future, having more eye exam, we've had patient portals for a while now, maybe 5-10 years already. So I don't know if that will help patients, having that patient portal. Also, having these teleretinal screening programs, becoming more broadly accessible to patients, having that report in simple language stating whether retinopathy is present or absent in the eye may help increase awareness in the future. I think getting that report to patients and finding the right balance of what's written in that report is potentially helpful to patients.
All right. Thank you, Dr. Silva. Up next, we have Dr. Amanda Bigot, who will talk about gait assessment and the evaluation of functional vision. She's an assistant professor of ophthalmology and visual sciences here at the University of Michigan.
Good afternoon. I want to thank Drs. Levine and Gardner for inviting me to get involved with the Mary Tyler Moore Vision Initiative and the conference organizers for inviting me to try to convince you all that gait evaluation should be a hot topic in the assessment of functional vision. I'm going to start with the premise that gait demonstrates function. This is not a new idea. In fact, in the physical therapy literature and in the geriatrics literature, walking speed has been called the sixth vital sign. The justification for that really bold assertion comes from years of evidence demonstrating that the way we walk is both representative and predictive of our overall functioning. This figure from a review article that brought together about a decade of functional research really struck me in how it stratified outcomes by walking speed. I had, for instance, never imagined how demanding it is to cross the street independently and safely, and I was sort of bowled over to see that there was no overlap in these review figures between those capable of walking their own groceries into their house and those who were expected to show cognitive decline over the next 5 years. But gait, as I'll discuss it today, is more than walking speed. It's a complex measure both conceptually and spatiotemporally, and we can evaluate gait in many ways. So this table guides my team's ongoing study of in-clinic and at-home gait in glaucoma patients. I'm an interloper here, I'm a glaucoma specialist, not a retina specialist. We certainly think about gait quality metrics that reflect pace, like walking speed, but we are also interested in how gait varies across time and across environments, and how smoothly and symmetrically participants walk. The harmonic ratio, for example, is derived from a Fourier analysis of trunk accelerations, and it's considered a measure of dynamic stability. So this brings me to how we capture gait. In one study I'll discuss, we used a floor mat, known as the gait right, to map footfalls. This approach provides lots of information about the relationship of one foot to the other, but it can't tell us much about how the rest of a person is moving atop their feet. And for that reason, in current studies, including the others that I'll describe, most researchers are fitting patients with wearable sensors like inertial measurement units or IMUs that can capture mobility in three-dimensional space and time. This image from my Kellogg collaborator, Laura Ojeda, who's here in the audience, shows what traces from a single IMU on the dorsal surface of a foot might look like, and how these can be used to recreate the motion of that foot. Another key benefit of wearable sensors is their adaptability to any environment. We're not limited to the sterile, predictable environment of the clinic, but we can study gait across varied terrains, as in this gait garden, or in a virtual reality environment, which offers so much flexibility in terms of building a walking course, or even, as we're doing sort of boldly now, in the wilds of a patient's home environment. With collaborators from the University of Pittsburgh, where they actually do have a lovely gait garden, though this one is in Switzerland, our current and planned work involves all three of these environments. At the American Glaucoma Society next year, you can hear me talk about the challenges of making sense of how a person actually moves at home, but that's a story for another day. So for all its complexity, gait is readily accessible with simple observation or painless instrumented testing. It's also, I should point out, influenced by both age and systemic disease. So I never knew until Lauro mapped it out for us how many different ways a person with common conditions of aging can find a way to walk in a straight line in 2 minutes. And finally here, I suspect I'm preaching to the choir. Gait, mobility, a person's ability to move independently through the world, these things are hugely important to their sense of well-being and their health-related quality of life. So I'm here today talking to you about all of this, specifically because gait is impacted by eye disease in characteristic, repeatable ways that we think can give us insight into that disease. For example, data from the National Health and Nutrition Examination Survey, or NHANES, showed that visual field loss in one or both eyes was associated with fewer daily steps and less physical activity overall, even when we control for other factors that slow people down. Our own work has shown that glaucoma patients, for whom loss of contrast sensitivity is an important, if undermeasured, disease feature, not only walk differently, but cannot adapt their walking to changes in the visual environment like lighting. So on this way too busy slide, I want to highlight a pattern that we saw across both our pace metrics and our variability metrics. Glaucoma patients showed us not only more cautious and variable gait overall, but slower and more variable gait in dim light, and most interestingly, I think, didn't recover their baseline gait characteristics when the lights came back on. So crucially, these changes were evident across the whole spectrum of visual field loss, which is to say, from the earliest asymptomatic stages of disease, because in glaucoma, we follow glaucoma suspects annually, just like our mild glaucoma patients. So we have tons of visual field data on people who do not yet and may never have glaucoma. And from a mean deviation of 0 decibels, we can see that changes in gait appear in glaucoma, mild, moderate, and severe patients. This is what gives gait features the potential as an early biomarker. These functional outcomes of subclinical neurosensory change is what we're now hoping to find in diabetic retinal disease. As an aside, I've stopped turning off the lights in my exam rooms for my patients since I saw these results. So this brings me to the thing of which I most want to convince you today, that we can usefully study gait in patients with diabetic retinal disease and potentially find and head off impending loss of independence and quality of life, as well as inform the performance outcome measures that Malvina Edelman described this morning. We're working from the assumption that microvascular and neurodegenerative changes reduce contrast sensitivity and impact visual field before diabetic retinal disease is clinically evident. Some of you are intimately familiar with this slide. Someone in the room probably wrote this figure. As was described this morning, one of the working groups for this organization has identified visual function tests that might serve as biomarkers in diabetic retinal disease, and importantly noted that both visual acuity in low luminance and contrast sensitivity suggest a risk of impairment, and that both contrast sensitivity and visual field loss are prognostic measures in this patient group. So I think we can use the 6th vital sign to take advantage of this. There's an important wrinkle here that I, as a person who mostly studies glaucoma, cannot overlook. In diabetic retinal disease, in addition to loss of visual field and contrast sensitivity, gait is impacted by other features of disease. So diabetic peripheral neuropathy leads to altered biomechanics and poor sensory feedback. Diabetic autonomic neuropathy impairs balance and increases patients' risk of falls. But while this may make it more complex, it also makes it all the more important to understand the multifactorial motor impairment that comes with diabetes and intervene before patients show us decreases in their physical activity. So here's a planned pilot trial for which our team hopes to acquire funding in the immediate near term. Dr. Tom Gardner and I, along with Laura Ojeda and my colleague and collaborator Niranjani Nagarajan, will recruit adults with diabetic retinal disease with or without diabetic peripheral neuropathy and corresponding normal controls for in-clinic gait testing wearing IMUs. As we did previously in our glaucoma patients, we'll vary the lighting conditions in which participants walk with an aim to first determine the impact of diabetic retinal disease associated visual field and contrast sensitivity loss on those gait metrics that I described, and second, to associate gait quality with patient self-report of the impact of their diabetic retinal disease using patient-reported outcome instruments. We're going to use the RETCAT-3 and a fear of falling questionnaire because we won't be lucky enough yet to have Chiran Jayasundara's disease-specific PRO. Detecting impaired gait allows us to get patients the therapeutic and technological support they need to keep the skills and independence they have. But more than that, it may help us find and fight diabetic retinal disease earlier. Thank you very much. I'm happy to take any questions.
Thank you. And actually, I'll start with a question.
Please.
You mentioned that diabetes has multifactorial impacts on ocular health in the eye and the way that it functions. Do you anticipate that you could detect from gait differences in, say, a glaucoma patient from a DRD patient?
That's a great question. When I first described this pilot to a mentor outside the field of ophthalmology, he said, "Oh, I get it. You're going to use AI to screen a video of people walking into a room and pick out the ones that have undiagnosed eye disease." I was like, that's the coolest thing I've ever heard, and I don't know if we can do that, but maybe. Because the ways that each disease state impacts each clinical functional measure differs. So we have quite a lot of information about what happens to visual field in glaucoma because I think Dr. Abramoff said earlier, his patients cry when he makes them do visual fields. I make my patients cry like that 35 times a clinic. So we have a lot of detailed data about how functional measures change in each disease state and the associations between each way that mobility changes and each functional vision test are likely to be different. So I'm hopeful if we look at gait in a detailed enough way.
Fantastic. Thank
Yeah.
you.
This is so awesome, and I didn't want to diss on glaucoma in public. So, sorry about that. Any principle or fundamental reason why you couldn't do this with an iPhone, which has an accelerometer, as you well know? Is there? I can understand why you say, well, I want 5 sensors, and maybe we can refine it. But is there any fundamental reason why it could not work?
No. I mean, the data, it's a good question. So there are lots of wearables that we have ready access to. I wrote a grant that used Fitbits once, and it didn't get funded. But when you have just one moving item attached to a person, you can get a lot of accelerometry, you can get GPS data, which is really interesting. You can't get a detailed understanding of how the body is balancing and moving in space, partly because the things that we carry with us don't fit tightly to our body, and partly because we don't have the relationship of multiple points. But fundamentally, no. Any wearable could theoretically gather useful mobility data on a person with eye disease.
So before I give it to someone else, if you have an iWatch plus an iPhone, now you have two and one is pretty tight.
Maybe.
Right.
If you always keep your phone in the same spot.
Well, sure, but my point is more, with two sensors, it's already better,
Yeah.
is what you're saying. Okay, yeah. Thanks so much.
Do you anticipate that your gait disruption is also applicable to young children who already have retinopathy?
That's a really interesting question. So none of this work that I'm aware of has ever been done in kids. In glaucoma, there's sort of a population reason for that our population of pediatric glaucoma patients is quite small. Most of our studies are done in adults. But it's a really important question. I think the fact that we've already discussed today that diabetic retinal disease is appearing in young children and is going undetected. And so there are probably contrast, sensitivity loss, and visual field losses that we're missing. I think it's the right question to ask because the changes in gait that we see in another disease model start from normal, start from the moment there's any loss.
Two quick questions for you. Number one, so I noticed a lot of straight lines on your figures. So how do you think gait is impaired having a patient walk in a curved line? And have you thought about implementing this in your studies?
I feel like I should put Laura on the spot, but I won't. So we talk a lot about how to use, when we have patients walk in a clinical environment, we do capture both straight line and turning data. The turning data, as you might imagine, is a little messier. Some people pivot when they turn, some people walk around a point. You can instruct them to do one or the other. And it gets worse when you put them in a garden environment or a home environment. But there are ways to deal with turns. We talk about turns a lot. And in the study the little pilot I just described, we wrote turns into the protocol, and we'll figure out if we can usefully use them.
Interesting aside, there's this Lou Ruvo Center for Brain Health in Las Vegas, designed by Frank Gehry, and there's no straight corridors in the building. All the hallways are curved, and supposedly this has benefit to the patients. When someone has dementia, they don't like straight hallways because there's some sort of claustrophobia associated. And next thing I'm wondering about is, you mentioned in your study that you're getting off the ground, you had two subgroups. You had one diabetic retinal disease with no peripheral neuropathy, and then you had another one with peripheral neuropathy. And how do you think those two conditions might synergize in the context of gait?
So I think the data from those with peripheral neuropathy is going to be harder to interpret. And my hypothesis is that it will bring out gait features that are associated with vision loss, sort of make them more dramatic, make them easier to see. But I don't know for certain because, full disclosure, when we enroll glaucoma patients, we usually exclude those who have known neurological reasons for impaired gait or known musculoskeletal reasons for impaired gait so that we're just capturing the vision changes. Yeah, good question.
All right. Thank you,
you so
Dr.
much.
Bickett. Okay, up next we have Dr. Fernanda Abelim. She will be discussing developing a patient-reported outcome for DRD, creating tools to capture patient voices.
Good afternoon. I want to thank you, the Mayor Tyler Moore, for this wonderful initiative. And today I'm going to talk about the development of a new patient-reported outcome measure for diabetic retinal disease. These are my conflict of interests. It's a common knowledge that diabetes is a systemic and complex disease that directly affects the eye, the kidneys, and peripheral nerves, and causes indirectly emotional and psychological distress. The emotional distress comes in many forms, ranging from burnout, depression, anxiety, and there's a growing number of evidence that demonstrating that those conditions impact the management of the disease and enhance the outcomes of the diabetic retinal disease. There are many therapies being developed across the globe to mitigate the disease burden. And concerning the retina, there's a need for better outcome measures to show efficacy and effectiveness. And although there are very well-established outcome measures like OCTs, OCTAs, FA, central vision acuity, contrast, we still have concerns about their sensitivity to capture early changes, subtle changes at early stages, their test-retest variability, and their true contribution to improvement of vision in a patient's daily life. And to that end, PROs have been an important tool to capture patients' perspective. For DRD, for example, several good PROs have been used in clinical practice and clinical trials, such as the EQ5, as well as the very well-known VFQ, and more recently, the RedCat. While they are very good tools, there are still some gaps remaining regarding the approach of patients with DRD. I had a chance to learn a little bit more PRO development when our group developed the MRDQ and the MVAC a couple of years ago. These PROs address a very specific group of disease, inherited retinal degenerations, which are diseases caused by genetic changes. And these two PROs were designed in response to the need for better outcome measure for IRDs as well, such as in clinical trials for gene therapy. The MRDQ is a disease-specific PRO descriptive of visual pathways, and it accounts for the accommodations patients make with time when they have vision loss. And the MVAC captures symptoms derived from cone and rod impairment that ultimately lead to emotional distress. The MRDQ has been used in many clinical trials and natural history studies, and early data have shown that the MRDQ has functional and structural correlations with static perimetry, microperimetry, FST, visual acuity, some OCTs, and autofundus autofluorescence, which is a very important trait to further validate a PRO. And in my view, very importantly, it can bridge improvements in functional tests and their impact on the patient's own experience. So for example, it might explain whether a change in a given functional test really impacts a patient's vision on the daily life. The MRDQ also has shown to be sensitive to change among disease groups, such as age, disease stages, phenotypes, meaning that its score may change as the disease progresses. So now that we have learned a lot and we understand that diabetic is a much more complex disease, we think about other key aspects that will be needed for creating a PRO for DRD. So we envision this as a multidimensional tool that assess not only vision, but other lifestyles, commonalities like diet, exercise, the family burden, one's emotional state, in order to have some agreement and balance between the clinical relevance and the patient experience, while also integrating clinical and ocular data with the psychological domains. So our objectives with this new PRO development is to identify, create a PRO that is able to identify meaningful visual function, especially in the early stages, identify other aspects of one's life that influence DRD outcomes directly or indirectly, identify barriers to diagnose and treatment. It has to be sensitive to change, reflects a diverse patient population, and all of this based on patient perspective and regulatory compliant. We are still in the middle of the development process, and this process follows 6 basic stages, and I'll go one by one. So phase 1 starts with gathering data from panel of experts. We gathered 4 groups of experts between April and May this year. And we get a multidisciplinary team that surrounds the care of a patient with DRD, such as retina specialists, patients themselves, low vision specialists, psychologists, psychiatrists, endocrinology technicians. And with this data gathering, we moved to the second stage, which comprises the development of open-ended questions to interview patients. So we created 76 questions addressing not only visual symptoms, but also no emotional distress and lifestyles features. And we interview adults, all adults from all stages of DRD with and without macular edema, both diabetes type 1 and 2. And we are trying still to be attentive to race, social, and cultural backgrounds. And for this purpose, we are partnered with the Wayne Institute as well. So here are the preliminary data from this phase. To this date, we have recruited 86 patients, the majority being between 45 and 60-year-old. The majority also white, and we're still looking to include a more diverse population. Next phase is the content item generation phase, which is basically to develop questions and their respective scales based on what we gathered from the interviews using qualitative analysis. The qualitative analysis is being done by a software called Atlas, and we do a thorough analysis of the transcripts by coding, which means tagging all the themes and concerns raised by patients. And this coding process is being done by 4 independent coders, and the process only stops when we reach theme saturation, or when, meaning that then no other theme and subject comes up. And then we use a word crunch tool to capture frequently used terms and expressions to be used in the construction of the items. And this phase is one of the most crucial phase to elicit content that is meaningful to patients using a language they can really relate to. Here's an example of one theme that came up. This diagram illustrates the main barriers to accessing care. More specific barriers include financial constraints, insurance limitations, transportation, difficulties, and limited physician availability. Here's another example demonstrating coping mechanism as one code, as a common concern. And from this parent code, we can always dig deeper and find which mechanism these patients can use as much as their frequency among this population. And as to the visual symptoms, we have coded patient symptoms based on the physiological areas of vision, such as central vision, contrast, color, scotopic, mesopic functions, peripheral vision, photosensitivity, depth perception, motion sensitivity, metamorphopsia, and they will lay the foundation for the development of the visual domains for the later stages of the PRO development. Here are some other themes that came up. You can see that there are many other aspects in one's life that may influence the outcome of DRD, such as lifestyle patterns, emotional concerns, workplace impact, among many others. In phase 4, we'll conduct cognitive interviews to make sure the questions and scales are clear on an 8th grade level and identify possible sources of ambiguity. And we plan to recruiting 25 patients, both from the Kellogg clinics and from the Wayne State. Our next step will be to pilot all the items derived from these earlier phases, and the goal is to capture the full spectrum of DRD. And for this purpose, we plan to collect data from 300 patients stratified by age, stage, and race, as long as it's possible. And finally, the last phase is the psychometrics and item reduction. In this phase, we statistically test the power of each item. We look for whether they are informative of the trait we are measuring and for their ability to discriminate patients with different disease stages and levels of visual impairments. We also make correlations between scores and clinical and demographic data to filter the best items and to create the domains of interest. And we plan to use age, diabetic control using A1C as a surrogate, the disease stage, whether these patients have gone through previous therapies, IV injections, PRP, medications they use. And there are many challenges along the way, and we've learned this a lot with the development of the MRDQ, and we'll mostly try to avoid floor and ceiling effects, test-retest variability, and we learned from the MRDQ that using anchoring points that the patient can relate to is very helpful. Assert clinical meaningfulness. We want to avoid questions that ultimately don't reflect or don't impact a patient's experience, and test the convergence with other well-established and known PROs as well. And with this tool, we envision as a promising tool to identify patients' most concerning visual dysfunctions, use it for target or outcome measures for eye therapies and low vision rehabilitation, target for emotional distress, whether it's a direct cause or if it directly affects the outcome of the DRD, understand the patient journeys to access to diagnose and treatment, and tackle how to intervene and when to intervene with these patients, possibly allow the development of policies to address these barriers, its utilization in the cost-effective analysis of potential new drugs, and even as a cohort design for clinical trials, in the sense that we might find a use for balancing cohorts in clinical trials by other unconventional measures. So instead of just using age or disease stage, we might want to stratify patients by a PRO result, such as poor adherence to exercise, low scorings to exercise, to diet, lifestyle, and the own patient's perspective, and ultimately create patient and population awareness. I want to acknowledge all the group that is making this research possible. And open to questions, and you can reach out anytime. Thank you.
Thank you, Dr. Abelin. We have time for one question. I'd like to keep us on track time-wise.
So I'm curious to make a connection to the previous talk. There was this seeming disconnect with people with early stage DRD and hesitancy to follow up, so on and so forth. I'm wondering, what stage are these PROs given? Do we do this interview after someone started treatment, or do you give it earlier just to get a baseline as to how someone's coping with early stages of potential vision loss?
Well, that's a great question, and I think it depends what's going to be the purpose of in which situation it's going to be used. So if you consider being used in clinical practice, I would say as early as possible, as long as the patient gets a screening picture or has a diagnosis of diabetes, either without DRD. And in a clinical trial setting, as a baseline visit to see whether there's a change, we can see change over time as well.
All right. Thank you, Dr. Abelin.
Thank you.
All right, this section's last speaker will be Dr. Jeff Sundstrom. He'll be talking about vitreous analysis for clinical assessment, staging, and patient selection for clinical trials, and he's an associate professor at Penn State University.
So first, I'd like to thank the organizers for inviting me here today. It's quite an honor and a pleasure. Before I get started and talk about some of my data, I'd like to take a step back and talk about what are the requirements to practice what we refer to as precision medicine. Almost every other aspect of medicine is able to practice this other than ophthalmology. And there's one barrier preventing us from being able to do that. The first step is you need ready access to either the diseased tissue or a liquid biopsy or biofluid. And I'm going to postulate that vitreous can act as a proximal biofluid for retinal disease in a manner very analogous to cerebral spinal fluid acts as a proximal biofluid for neurologic disease. You then need a diagnostic assay, which we've been working on. And we do have very specific treatments, obviously for anti-VEGF, as well as anti-Ang2, and many, many more in the pipeline. So we're actually inverted from most other fields of medicine. We're giving very specific monoclonal antibodies without measuring the burden of those targets in the disease of these patients. And because of that, I think it comes as no surprise that only half of our patients respond well to anti-VEGF treatment. And I think a trial that many of us would like to do would be to see, is there a way to identify who is going to respond to treatment and who's not going to respond to treatment? I think the patients would greatly appreciate that. Less treatment burden, less cost. Maybe we can even, by selecting different drugs, improve their visual outcomes. And then as these monoclonal antibodies are being more readily available, easier to make, I see the future we're going to have 5 different treatment modalities available. And the retina specialists are going to be in a position where they're going to have to decide what drug are they going to use for what patient at what time. And that is, by definition, precision medicine. And so what we'd really like to do is to give the right treatment for each individual patient at the right time as they progress through various stages of diabetic retinopathy disease. And by doing so, we can optimize the chance of improving or preserving their vision. So the approach that we've taken over the last 10 years or so is to develop a device to safely acquire vitreous in a clinical setting. And we've worked quite hard at developing proteomic techniques ultimately to generate a biomarker panel to predict response to treatment and or identify novel targets to treatment. So this is how I see the current state on the left. If I'm going to talk about the biopsy device here in a moment. Assuming that we could safely get vitreous in a clinical setting in less than a minute or two, and we had some vitreous at our disposal, and we're not measuring or using it for anything, we're still just treating with anti-VEGF drugs. We all know the response rate is 50%. But if we take that vitreous, we do some molecular analysis, maybe a multiplex ELISA, and figure out which targets are driving that patient's disease at that specific time, we could then choose a very specific drug and increase the outcome for these patients. So maybe half of these patients have a disease at a certain stage that is VEGF driven. Others may have a portion of their disease that's Ang2 driven, TNF alpha, IL-6, and so on. So that's sort of our idealized schema for how we'd like to move forward. Being able to stratify patients has a tremendous advantage for pharma and patients as well. So on the left-hand side, you can see some failures of drug development back in 2019. And these, I think in part, some of these drugs failed because they were taking all comers. They didn't just take patients that had elevated PDGF, they took all patients. If they were able to measure those patients ahead of time and only enrolled patients with elevated PDGF, perhaps that drug would be available to patients today, and we could be using those for patients that have that factor driving their disease. Overall, this would end up resulting in more drugs available for more patients, and therefore improving vision in these patients. So quite some time ago, Tom Gardner and I, along with Laura Ojeda, we decided that it would be great to be able to make a vitreous biopsy device to safely acquire vitreous fluid in a clinical setting. These are the design requirements. Certainly needs to be safe, rapid, and reliable. The cost of goods is about $50 to make. It takes about 1 or 2 minutes to aspirate this fluid. It's a 25 gauge needle, and it has a cutting action just like the vitrectomy machine in the operating room, which on the other hand costs several hundred thousands of dollars and takes several hours to acquire. These are some various iterations of the device as it's progressed along. And as we know, physicians are stubborn by nature, and we very specifically wanted to make a device that did not need any additional capital equipment and worked into the current clinical workflow. So just like an injection, we'd place a speculum, insert the needle, activate the device, and aspirate the vitreous. We've set it up so that we can then simply remove the syringe from the luer lock, put a cap on it, and transport it to the laboratory for analysis. On the left-hand side, you can see the vitreous biopsy device working on a pig eye, which is a very thick vitreous, and it's aspirating that fluid no problem. On the right-hand side is a post-mortem human eye. You can see the stained vitreous being aspirated into the cutter when the vacuum is pulled on the syringe. So in summary, we have successfully created a vitreous biopsy device that could be used in a clinical setting. We have a device manufacturer that we've contracted with. We are building several devices for preclinical testing and all the necessary safety tests that we need to do. We're hoping to have FDA approval in 1.5 years or so. And once that's done, we'd certainly like to work with others and get multi-center prospective clinical trials moving forward. What are we going to do with the vitreous when we have it? And so we've spent quite a bit of time analyzing vitreous and optimizing different proteomic approaches to figure out what we can learn about retinal disease by looking at vitreous. As we all know, animal models do not fully recapitulate the human disease. We cannot biopsy retina, so we thought vitreous was the next best possibility. Again, very analogous to CSF for neurologic disease. This is a very quick study we did many years ago, proof of concept, pooled sample from 5 patients with diabetic retinopathy and control. When we do mass spec proteomics and pathway analysis, the data tells us that the 2 hallmark lesions of diabetic retinopathy are present, vascular proliferation of vascular cells, as well as neurodegeneration. It also pointed out a potential novel pathway, the Wnt and beta-catenin pathway. My former PhD advisor, Dave Antonetti, had been working on this pathway previously, and Jeremy Nathans had discovered it quite some time ago in the context of Norrie disease. A company called iBio, led by Tony Adamus and several other leaders in the field, have since taken an antibody that is a Wnt agonist. It's passed phase 1 trials. I have no financial relationships. I'm not taking credit for this drug. It's simply a use case that states potentially looking at vitreous could help you identify novel targets for the treatment of diabetic retinopathy or other retinal diseases. We did go back and look at the original data and ask the very simple question, why is the vitreous so information rich? And I'll briefly say that, in my opinion, we wrote this paper in 2018. Each of our eye contains about 10 billion exosomes, or extracellular vesicles. These are well known to mediate cell-cell communication. So when we're sampling vitreous, we're literally listening into the phone conversations that's happening between cells in the eye, and I think that's why the vitreous is so information rich. More recently, we've done a much more robust trial. This is mass spec proteomics. I'm not going to get into the details. The purpose of this trial, of this experiment, was to ask the question, how many patients would we need to enroll to trust our pathway analysis and bioinformatics platform? Is it thousands, 10,000s? It turns out that it's around the order of 25, so very feasible. So we like that number. We were also able to reduce the cost tenfold for each sample by using a multiplex analysis. I apologize, a slightly complex diagram here. You can see on the right-hand side, mass spec can only get so deep. It can't really detect proteins that are not very abundant. There's no amplification step. There's a newer method out called Olink. It uses barcoded antibodies, and it does have an amplification step, and you can detect up to 5,000 proteins down towards the less than nanogram per mil level. We optimized it on a targeted platform that they have with an N equals to 6. And you can see that VEGF was elevated, and then there was a trend towards Ang2 elevated with simply an N equals to 6. I'm not showing it here, but the other beauty of the Olink platform is it only requires 2 microliters of fluid. So you don't need a lot of fluid to get this test done. When we compare the mass spec proteomics to the Olink, you can see that we've greatly expanded our coverage of the vitreous proteome by over 2,000 proteins. And that's critical because now we have enough information to feed into the bioinformatics software in an unguided, unbiased way. And on the right-hand side, you can see what are predicted to be the upstream regulators of diabetic retinopathy. I've circled VEGF. As we all know, that's our workhorse. Interleukin-6, I believe, is in trials with Roche. And there's TNF-alpha is known to play a role. And so we're now getting deep enough with this discovery platform where we could potentially identify novel targets for treatment. I'm going to go ahead and skip this slide for the sake of time. Be happy to discuss this with anybody later. And I'll briefly point out, and I won't get into the details, but thanks to the help of Chris Gates and Nick Carruthers, we've worked backwards with single-cell RNA-seq analysis and tried to tie back the differentially expressed proteins to which cells might be actually releasing these proteins into vitreous. And it's quite a different pattern when you compare diabetic retinopathy to retinal detachment. One thing that jumps out to me is that in both cases, retinal ganglion cells seem to be providing quite a bit of proteins to vitreous. And so reattachment rate is close to 95 or greater than 95%, but visual outcomes are poor in retinal detachment. Perhaps it's not the rods and cones. Perhaps it's retinal ganglion cells, which goes well hand in hand with what we know about diabetic retinopathy as well as glaucoma. So in summary, vitreous, in my mind, is comparable to CSF for neurologic disease. I think exosomes make it information rich. We know how many samples we need for reliable analysis, and we've identified ways to determine which cells might be responsible for vision loss in these diseases. As we move forward, we hope to have that device ready, FDA approved in a year and a half, and develop a smaller multiplex panel, maybe 50 to 100 analytes, and then use that in a prospective trial with potentially hundreds of patients in order to begin to try to predict response to treatment and or identify novel targets depending on how we decide to set up the studies. And just circling all the way back to the beginning, this is a schematic of what we hope to see in the next 5 or 10 years, where instead of a 50% response to treatment, hopefully we can get response to treatment closer to 95%. As with all the projects discussed here today, it's a major team effort. I'd like to thank everybody for helping at Kellogg with the biorepository. I've already talked and thanked Tom Gardner and Laura Ojeda for the biorepository, the the biopsy device, and Chris Gates and Nick Carruthers for the bioinformatics analysis. Thank you.
Thank you, Dr. Sundstrom. All right, question.
As a patient, I'm looking at the device and cringing. What have you studied the impacts of kind of what happens after it does? Like, what's the recovery time? Because 60 seconds is a very long time when you're sitting there with your eye being held open and something sharp going into it. So.
Yeah, understood. We've tried to make it as small and ergonomic as possible. It is a 26 gauge needle, slightly larger. It will be self-sealing. It might be a little bit more painful than an injection, but not significantly more. And certainly if needed, somebody could go to the operating room for some mild sedation, so.
Hey, hi. In terms of the protein concentrations that you're measuring, right? You might consider, right, how fast the fluid is leaving the eye. If they're phakic or pseudophakic, or if they've had a vitrectomy. So you might consider that in your trials to make sure you capture that information. And maybe if you take a ratio of that to some protein that you know is always going to be releasing at the same amount, like albumin or something like that, you could then take ratios of proteins to try to compensate for the leaving rate of fluid transfer out of the eye.
Sure. Yeah, I agree. Fluid dynamics of vitreous are poorly understood, but certainly the half-life of an antibody is much less in an eye that's already been vitrectomized. And a lot of people are looking at aqueous, which does, as you mentioned, based on lens status, could present a problem. Instead of having a two-chambered eye, now you have a one-chambered eye, and there'll be quite a different protein expression profile.
Yeah. So you touched a very important issue of the precision medicine, but still this is an invasive procedure. And especially if I think clinical application, for example, outside of the US, we do the injections not in the office setting. And on the other side, the office setting has a major rate of endophthalmitis. So I can envision the use of this, let's say, just immediately before the intravitreal injection, the treatment. So how fast is your response to the response that you get when you do this biopsy? How fast is it?
If it was in-house, it could be done that same day, so.
But not in minutes?
No, not in minutes.
No,
Yeah.
so then you need, let's say, two like injections or two procedures in the eye if you want to target specifically, let's say, the patient.
That's correct. You'd probably need an additional procedure, but you could potentially increase your response rate from 50% to 95% and overall get a drastic reduction in your injection burden and potentially have better visual outcomes.
Thank you.
Question. I think that what you touched on is really relevant. We have all these patients and we don't know who's responding, and we have the shotgun approach to treat them. My question is, people have looked at serum biomarkers. Is that something that you've looked at or are considering that can help us, and that might be less invasive than this particular device?
Yeah, so we'll certainly consider that. The typical workflow for liquid biopsies is to start proximal to the tissue where it's more concentrated. Once we identify a handful of markers that might be predictive to treatment, then we would certainly try to use a blood-based test.
All right. Thank you, Dr. Sundstrom.